Okay, so once the bleb is failed, what are the options that we have? It is the most successful procedure, but still, as we have discussed, the failures do happen. And trabeculectomy is very labor-intensive job. So the job, it doesn't finish with the surgery. And in this one of the studies, if you look at 78% of these cases post-operative, they needed some kind of a bleb management, bleb manipulation in the post-operative period. And and the bleb massage is very important, and half of them would need it early or even late. But bleb massage is usually useful only in the early post-operative period, starting from day 1 to perhaps 1 or 2 weeks, and after that its utility gradually goes down. Suture removal, we are using, most of our trabs are now with the releasable sutures, so I think suture removal is required again very often, almost half of them. If you have suture tight enough, then actually all of them should need suture removal, but I think even after tight suturing, some fluid still goes into the subconjunctival space, so it's not a watertight closure always. So that's the reason half of them will still filter without releasing the suture, but that's another common procedure which is required. And also supplement of 5-fluorouracil might be needed, and then of course we need needling for some of these blebs, which is again almost 20-25% of the cases we need that. In spite of that, the failure rate is quite significant, and all that you have done, all the manipulations, and still over a period of 3 times, or I would say within 1 to 3 years, 1/3 of your trabs they are likely to fail, or they will need something extra. So what are the options to salvage these blebs? As we have been discussing, it's important to look at the tissue, the bleb, very carefully, and try to ascertain what is the likely cause in that particular bleb which is leading to failure. Is the conjunctiva quite healthy, mobile, intact, or there's a fibrosis there, or a vascularization there, or there's a inflammation which is still going on? So that we need to ascertain, because next step would depend on that. We also need to check the ostium that we have created, the trabeculectomy fistula, and that should be patent. And then we also try to ascertain what is happening to the skull flap. It is visible, it's not visible. Is there a big scar tissue there? Is kind of a tether to the scalar bed, or it is elevated? And at this stage, you could also do a AIOC2024 or UVM to see whether there's a fluid pocket underneath the bleb or in that area or not. So if there's a fluid pocket there, that means that there's a communication which is between the anterior chamber and the bleb is maintained. And it's basically the fibrosis which is causing the trouble. So if the conjunctiva is healthy and you have a fluid underneath there and the ostium is patent, I think what you can do is you could consider trabeculectomy needling in those cases. So this is 29-year-old female, both eyes GOAG, one-eyed, advanced glaucoma with almost total cupping, and right eye mitomycin C was done some years ago. The bleb was nice, diffuse, and controlled pressure for almost 3 years before it started rising, and then we had anti-glaucoma medicines, and the pressure kept on. Was not controlled, and it was progressing. So you can see the pressure is about 23 with the oral Dimox and acetazolamide and 4 topical. So you can't really go beyond that. So what we did was, you can see the bleb area is, the conjunctiva looks okay. There's a fibrosis, there's no bleb there, the ostium was patent. So this was a patient 4 basically. So what we do in the needling, so we decided to do needling. So this, what I'm injecting is actually local anesthetic. So this is under topical anesthesia, so I haven't given any retrovulvar. And after you inject the local anesthetic into the subtenon space, then you mobilize. So what I'm doing is I'm using that local anesthetic as a hydrodissection and to mobilize the tissue, and then you go posteriorly with the bent needle, 26 gauge needle, and now I am actually cutting that fibrous tissue which is there in that bleb area. So I'm going, entry point is quite away from the limbus because I don't want that area to leak, and then you just gradually you cut that tissue, with the sweeping motions. And now you also monitor the IOP, and some point of time the IOP will go down, and your bleb, now you can see the bleb has started forming again, is increasing. Now you can see the bleb is increased. And because if you leave this bleb, the eye becomes hypotonic. So if you on table, if you see the eye pressure is too low, then you can create a paracentesis and inject some fluid till don't leave the eye grossly hypotonic. And that's it basically. And you could inject 5-fluorouracil on the same day in the adjacent area, or you can use for 5-uracil in the postoperative period. So this is how this bleb behaved. This was the 1 week after surgery. You have a diffused bleb and the AC is nicely formed. And 3 months later, the IOP is 10 millimeters of mercury again, and vision is maintained. So bleb needling is a good procedure for the failed trabeculectomy blebs. And as you can see in this study, 5 FU augmented bleb needling within 1 year, one year of trap can lower IOP more than 20%, and that is a lasting effect and could last for up to 2 to 3 years again. So practically, you are re-establish filtration in these bleb using. The other method could be that you could do a trabeculectomy, which can be redone in the same eye. So this is 57 years old female, angle closure coma. Both eyes trabeculectomy was done in 2007. There was a diffuse filtering bleb for 14 years, and after 14 years, the bleb starts scarring, and actually it fails, and IOP is high, the visual start progressing. And we tried needling first in this patient, but that kind of failed. And then we have, you can see the IOP is high in this with multiple drugs. You have 6/9 visual acuity, and this is what we did for this patient. So we revised this bleb, and you can see this is the normal procedure here. So what you do is basically I have opened up that tissue there, and this is the old trabeculectomy site which has opened up, identified the previous the area of the bleb, and then like you do trabeculectomy, you just open up mostly with a blunt dissection. You would be able to identify the edge of the flap and then just open it up. And once you achieve that, you could put a couple of sutures if required in that area and close it like it was any other trabeculectomy was done. So once you had opened it up, you could do that. Now once open now, it starts flowing, and then you just close it like any other trabeculectomy. And this is the post-operative period, because the new flap that we have created is the old flap basically, which may not be as smooth as for the old one. So you could get some extra leakage from that point, and the IOP is a little on the lower side, and bleb is a little flat. But this has been tried earlier also, and you can see the posterior revision of the bleb can have long-term outcomes, and 80% of the cases it would be successful and without any requiring anti-glaucoma medicine. So this is another viable procedure. The other procedure we do is the bleb revision through an external keyhole incision, and again, this is a 55-year-old male PUAG patient. 2 years, TRAV was done 2 years back, and you can see it's doing very well, except that the bleb has now failed, and your UBM shows that the trabeculectomy site is patent there, but you have that fibrosis around it, and you have the clinical picture there. So what we do here is that you can create a small opening in the posteriorly. Now this is the failed bleb, so I'm going a little more posteriorly. And you make a small keyhole incision, and that through keyhole incision you dissect mostly with the blunt dissection, just by the opening action of the scissors. And just mobilize that tissue, and once you have mobilized that tissue enough, you create pockets on either side. it's not moving. Okay, you can create pockets on the either side basically. And in, now the video stopped working. Okay, I'll just show you this video and then we'll stop. We have 5 minutes, I guess. So I'll let this video play and then, we'll close. So just keep opening, the tissue. So just mobilize the tissue. I'm basically trying to go under the scar. So there's a scar tissue there. So I'm not actually excising the scar. I'm just going on the scleral plane. And now you can mobilize on both the sides. So this is kind of beyond the posterior edge of the flap, and then you have to put some mitomycin C like you do for other traps. And after you have done the mitomycin C application, wait for 2 minutes or 3 minutes, whatever the time frame that you had chosen. Have access to the anterior chamber through paracentesis. Remove the mitomycin C and wash off that area. And now this section is carried out further. Now you'll see that you are going under the flap just by the opening action of the scissors. And at some point you will see the aqueous egress. Now you can see the aqueous is coming in that area. And you can actually enlarge that a little bit more. And then inject fluid through the side port, and you can see the fluid is coming into that incision. Now, once that happens, you don't have to do anything. Just close the wound, and procedure is done. And this is in the post-operative period, you could see the AC is nicely formed. You have a bleb there, and the pressure is controlled. And this is after, follow-up of 3 months. You have a nice bleb, and the pressure is well controlled. But if you have a situation like then when the bleb is totally scarred, then you have no actually option of revising the bleb. The best would be to just excise this bleb and put a skull patch graft and to secure basically to make the eyes safe, and later on do it, you could do tube surgery in these eyes. So if everything fails, then basically you have the tube surgery will come to your rescue. So in summary, trap failures are common, and a number of options are available. Each of various interventions have a specific role, and it depends on the situation at hand that which role, what you will do. And there's no procedure which is perfect, and it's possible to revive failed blebs in most cases. And however, the success rate of the retrap is lower than the prime trap. And GDD play an important role here. And thank you very much. Thank you very much.